Very good evening to all of you. So, the task provided to me is to talk about antimicrobial therapy for lower respiratory tract infections. I'll be walking you through the recommendations and rationale of antibiotic therapy in lower respiratory tract infections, both in community and hospital-acquired settings. So, what is community-acquired pneumonia? Is presence of lung inflammation with sufficient extent to lead to signs and symptoms or radiological features without any contact with the hospital setting, that it should be of community acquisition. It's an important, one of the important causes of infection and causes a lot of socioeconomic impact also. And India accounts for about 23% of global pneumonia burden, with the high case fatality rate between 15 to 30%. These are some epidemiological features, facts about pneumonia, that the mortality has remained unchanged between 2005 to 2015. And there had been a steady increase in hospitalization rates, including ICUs due to CAP. Mortality rate for CAP is less than 5% for outpatient patients, outpatient cases, and it rises to around 10% in admitted patients, and can exceed to 30% in patients admitted to ICUs. The elderlies and children, they have higher mortality and morbidity, and it has been reported in sub-Saharan Africa, Southeast Asia, and South Asia, they have higher documented fatality. The common organisms which are incriminated in etiology are typical bacteria, atypical bacteria, and various respiratory viruses which have been listed in the table. The commonest amongst the bacteria is Streptococcus pneumoniae, and amongst the atypical bacteria, Mycoplasma, Chlamydia, they are common infections encountered in day-to-day practice. After the advent of the menace of COVID, SARS-CoV-2 is now an important cause of respiratory pathogens causing pneumonia. Otherwise, influenza viruses and respiratory syncytial viruses are the common viruses which cause pneumonia. The microbial etiology of CAP, as according to the reported literature, is different in different areas. In USA, 61% patients do not have any pathogen detected, and respiratory viruses are commonest organism incriminated or demonstrated to cause pneumonia. Europe also has almost similar pattern, but in contrast to USA, the causative organism as bacteria as the pathogen is more commonly demonstrated after no pathogen identified. And in India, the condition is different, that only 6% is actually found due to respiratory viruses, and 65% is because of bacterial infections. But this is this epidemiology largely is reflected by the amount of reporting which is done and kind of literature which is published. So there is a lot of underreporting from India and other countries to actually pinpoint the correct etiology. In India and other tropical countries, Mycobacterium tuberculosis is an important cause of lower respiratory tract infection, which can present as acute infection also at times. Scrub typhus, leptospirosis, malaria, dengue are important disorders which can be close differentials, and they are distractors for the early recognition of community-acquired pneumonia. And a soil bacterium, that is Bacillus pseudomallei, is a causative organism from melioidosis, which is an important cause of pneumonia and sepsis in India and other Southeast Asian countries. The treatment of community-acquired pneumonia actually depends on the site of care and the severity of illness. So there are some rules and scoring systems and ways to decide how you decide where the patient of pneumonia to be treated. That is called the risk stratification, for which some criteria have been laid down by American Thoracic Society and IDSA together, in which there are major and minor criteria, presence of one major and three minor criteria to the extreme left of your screen tells you that patient has got a severe community-acquired pneumonia and it fulfills the criteria for admission to the ICU. However, another scoring system, that is CURB 65, which contains of 4 parameters and age more than 65. If you have 0 to 1 points, 0 outpatient management will suffice. 2 points inpatient management may be considered. However, more than 3 points inpatient management is necessary. Similarly, a pneumonia severity index has been designed, in which points have been assigned to various factors which have been listed in this table, and how to interpret them, that if the score is patient less than 70, patient is low risk class 2, can be managed on outpatient basis. Score more than 71 to 90 can be managed on outpatients versus small period of observation in the ER. Patient which has a score more than between 90 to 130 or more than 130, they have to be admitted. And these are some other scoring systems, that Smart COP and Smart Co. They have similar performance as Curve 65 and IDSA criteria. So ambulatory care, that is outpatient care, should be offered to patients who are otherwise healthy, do not have any comorbidities, and they have a PSI score of PSI class 1 or 2, or CRB 65 score of CURB 65 score of 0. Moderate community-acquired pneumonia is termed as hospital admission, requiring hospital admission in patients who have resting SpO2 less than 92% on room air, or they have a PSI of 3 or 4 with a CURB score of 1 to 2. However, in patients who fulfill the criteria for IDSA criteria for severe community-acquired pneumonia, they should be treated in ICU. They also have CURB 65 score of more than or equal to 3, or pneumonia severity index of 4 to 5. So outpatient antibiotic therapy, the basic principles are that for all community-acquired pneumonia patients, an empiric antibiotic therapy should be designed to cover for at least Streptococcus pneumoniae and atypical pathogens, and coverage should be expanded for patients with comorbidities, history of smoking, recent antibiotic use, and presence of structural lung disease. So these are the recommendations from the 2019 community-acquired pneumonia IDSA ATS guidelines, that in patients who do not have any comorbidities or do not have any risk for MRSA or Pseudomonas, which I'll be telling later, can receive amoxicillin or doxycycline or macrolide. But important caveat is that this should be only used in areas where macrolide resistance is less than 25% for pneumococcal infections. Patients, macrolide should only be used if the documented resistance is less than 25%. However, in patients who have comorbidity, that is chronic liver disease, chronic renal disease, or atherosclerotic cardiovascular disease, diabetes mellitus, alcoholism, malignancy, or asplenia, they should be treated with amoxicillin clavulanate combination, a third generation cephalosporin, and a macrolide, which can be azithromycin, clarithromycin, or clarithromycin according to the clinician's choice, or a monotherapy with respiratory fluoroquinolone is recommended by IDSA ATS. However, this does not hold true for Indian population because of levofloxacin being a very, very important second line anti-tubercular drugs, and it is our duty to inform others and also prevent this rampant use of misuse of respiratory fluoroquinolones, so that this antibiotic could be prevented, as it is a very, very important tool or of the armamentarium for management of MDR tuberculosis all over the globe. As I told you that in the previous slide, that MRSA risk factors for MRSA and Pseudomonas, they are listed in this table. For MRSA, presence of colonization of past infection with staph, or hospitalization with receipt of IV antibiotics with the within prior 3 months, ESRD, participation in contact sports, injection drug use, crowded living conditions, prisoners, recent influenza-like illness, presence of necrotizing cavitary pneumonia on X-ray, or presence of empyema. And for Pseudomonas, it is colonization of past infection, receipt of IV antibiotics in last 3 months, presence of immunosuppression, presence of structural lung disease like cystic fibrosis or bronchiectasis, or TB sequelae also, or patient who have repeated exacerbations of COPD requiring frequent glucocorticoid or antibiotic usage, presence of history which suggests that a probability of aspiration pneumonia is there, or presence of multiple medical comorbidities like diabetes mellitus, alcoholism, etc. So this is all about outpatient therapy of community acquired pneumonia. Now coming to the inpatient antibiotic therapy, non-severe pneumonias without any risk factors, we can give ampicillin sulbactam or a third generation injectable cephalosporin plus a macrolide. Similarly, here also in a non-severe inpatient, monotherapy with respiratory fluoroquinolone is recommended. However, the same thing applies here also. It should not be used in Indian context. Patient who have risk factors for Pseudomonas, who do not have risk factors for Pseudomonas or MRSA, but there is some contraindication to use of macrolides or fluoroquinolone. In that, in those patients, doxycycline can be added to the antibiotics suggested in the previous slide. Now, for patients who have validated risk factors for Pseudomonas or MRSA, in these patients, apart from broad spectrum cover, which has been listed in the previous table, linezolid or vancomycin can be added in appropriate doses. And in patients who have risk factor for Pseudomonas, astronam, cefepime, ceftazidime, that is cephalosporins, which have anti-pseudomonal activity, which can be cefepime, ceftazidime, or cefoperazone sulbactam, or piperacillin tazobactam, or carbapenems like imipenem or meropenem should be used. Important question which is asked, that what should be the appropriate duration of antibiotic therapy in community acquired pneumonia? Actually, it is guided by resolution of all vital sign abnormalities like heart rate, respiratory rate, blood pressure, oxygen saturation, and temperature. And patient has normal meditation, is able to eat and carry out his daily course. But antibiotics should be continued for at least 5 days or to a point where patient achieves clinical stability. Because inappropriate therapy can lead to clinical failure, which is defined as according to different parameters, that is presence of symptoms, recurrence of symptoms, vital signs, laboratory features, radiological findings, and the need for invasive procedure or treatment changes. These are the points which decide or diagnose clinical failure. And there can be various causes, and although it is not I mean in the part of in this lecture, but the causes can be host related, drug related, or presence of complications such as pleural effusion and empyema, or pathogen related causes which should be dealt appropriately or accordingly. So empiric therapy of community acquired pneumonia, severe community acquired pneumonia should cover the core pathogens. The core pathogens are Streptococcus pneumoniae, Haemophilus influenzae, non-drug resistant enteric gram-negative bacilli, bacteria, or Staph aureus and Legionella species. Along with that, an empirical cover of drug resistant pathogens, that is Pseudomonas, MRSA, or other enteric gram-negative bacteria, which are ESBL producing bacteria risk factors are present. So it is very difficult at times that how to treat these kind of patients who are coming as a severe community acquired pneumonia, admitted to the ICU, but you are not able to decide exactly you should cover for DRPs or not, because under treatment will lead to increased mortality and morbidity, and over treatment will produce drug resistance. So there are some people have published a lot of literature for predicting presence of DRPs in community acquired pneumonia, in which two authors, that is Shore et al. And Alberti et al., they had proposed a scoring system in which they can predict that how whether a patient has a risk factor for harboring drug resistant pathogens or not, in which the Shaw et al.'s criteria showed a good negative predicted value, and in Alberti criteria, value of 3 to 12.5 had a high probability of having a drug-resistant pathogens. But these are not clinically validated scoring systems. Couple of scoring systems which have been clinically validated in cohort studies. They have among them Shindo and Webb. These are the two authors which have published a good, scoring system in which the second one, that is on the right one, has got a very good sensitivity and specificity to predict presence of drug-resistant pathogens in patients with severe CAP, and they can guide you to add an additional coverage for drug-resistant pathogens in patients with severe pulmonary pneumonia who otherwise do not fit into the criteria for having validated risk factors for developing for having Pseudomonas, MRSA, or ESBL producing organisms. Coming to nosocomial pneumonia, nosocomial pneumonia is LRTI that was not incubating at the time of hospital admission and presents clinically 2 or more days after hospitalization, but within 2 weeks mostly. Pneumonia that presents sooner should not be regarded as community acquired pneumonia. And ventilator associated pneumonia is nothing but nosocomial pneumonia, which develops among patients who are on ventilator. VAP is defined as pneumonia that presents more than 48 hours after endotracheal intubation. In the previous latest guidelines for management of CAP, the ATS and IDSA have removed the word healthcare associated pneumonia because it was found that the belief that they had an increased rate of infection with drug-resistant pathogens was not found to be true. In fact, in retrospective studies, it was found to be counterproductive. And there were worse outcomes when these patients were covered with broad-spectrum antibiotics, which were covering for drug-resistant pathogens if given in an empirical manner. Patients meeting criteria for healthcare-associated pneumonia should not be empirically treated for coverage of drug-resistant pathogens. So here there is a case scenario in which elderly gentleman is taken with acute chest pain to the hospital, found to be ST elevation MI, and intubated upon admission and sent to coronary care unit. Primary PTCA is done with a drug-eluting stent. 2 days after the admission, patient develops ventilatory requirement increase and fever of 38 degree centigrade. Sorry for the typographical error. TLC of 17,100, procal of 0.37, tachypnea, but the patient is not in shock. A chest radiograph shows developing consolidation in the right upper lobe. The senior resident calls you what antibiotics to be started. What would be your choice? Piperacillin, tazobactam, vancomycin plus levofloxacin. Unfortunately, no. I mean, the choice should be cefepime plus vancomycin. Why do I say so? Because diagnostic, let's take me to the diagnostic criteria of VAP. It is 2 or more of the following clinical features, that is temperature, leukopenia or leukocytosis, purulent tracheal secretions, and decreased oxygenation, plus a chest X-ray compatible with pneumonia, that is presence of alveolar infiltrates, air bronchograms, and new or worsened infiltrates, plus a clinical pulmonary infection score of more than 6. The CPIS is a complex scoring system which contains 6 parameters which have given points from 0 to 2, and it is calculated by adding the numbers. So a CPIS of more than 6 plus 2 of the clinical criteria and a radiographic criteria. These makes a diagnosis of VAP. So in this patient, if you see, this patient had presence of symptoms, increased ventilatory requirement, fever, leukocytosis. Patient was not in shock, and procal of 0.37, and there was a radiographic suggestion of pneumonia. So this patient qualifies for a hospital-acquired pneumonia, and in hospital-acquired pneumonia, we have early onset pneumonia, that is less than 96 hours, or late onset more than 96 hours. In less than 96 hours, the usual etiology is Streptococcus pneumoniae, Klebsiella, and less commonly, other bacteria which are responsible are Streptococcus, Haemophilus influenzae, Enterobacter, E. coli, Proteus, Serratia, and Staphylococcus aureus. Along with that, if the patient has got risk factors, which I had previously described during community-acquired pneumonia, that is for Pseudomonas, Staphylococcus, that is MRSA, and ESBL producing Enterobacteriaceae. These organisms have to be covered. Now you'll ask why this patient received cover for Staph aureus. The answer is that in various studies, amongst which this one is a nice one which I came across, that in early onset VAP, there was amongst all pathogens, the only important difference was between MRSA, which was statistically significant, and gram-negative pathogens in total, in general. So any patient who has got early onset VAP, especially after a percutaneous intervention procedure and developing early onset VAP, should be covered for MRSA as an empirical manner, and definitive. For definitive therapy, investigations should be sent. So that is how we came to conclusion that these antibiotics should have been started. Other factors which should be kept in mind for extended etiology, that is presence of drug-resistant pathogens, is other than the duration of hospitalization, recent hospitalization, history of recent hospitalization, prior use of broad-spectrum antibiotics during current hospitalization or within 90 days of admission, prior isolation of multi-drug resistant organisms, and presence of immunosuppression. So when we have decided to give definitive therapy based on various, based on the results of the microbiological specimens which you have given, it is recommended that de-escalation should be done rather than completing the fixed course of fixed duration of treatment. Use confirmed susceptibilities to provide targeted therapy, and you should optimize pharmacokinetic and dynamic properties of antibiotics, some of which were very nicely covered by Professor Narayan Prasad. And in principle, general principle, that antibiotics should be started as early as possible. You should draw cultures before treatment, and a quicker time to antibiotic administration is associated with better outcomes. Variability exists among institutions, so a local antibiogram or local microbiological data should always be adhered to, or should always be referred to before starting or selecting antibiotics. And history of allergies, previous history, and comorbidities should be taken into account. So to optimize pharmacokinetics, one should be knowing that the antibiotic which you are giving is a concentration dependent antibiotic or a time dependent antibiotic. In meta-analysis of 3 studies which determined that whether pharmacokinetic pharmacodynamic optimization led to better outcomes, it was found that they were associated with less mortality and reduced ICU length of stay. And in another meta-analysis, it was showed that it was associated with improved clinical cure rate. So while selecting your antibiotics, such as carbapenems or penicillins or cephalosporins, continuous infusion to keep the antibiotic, or prolonged infusion to keep the concentration above the minimum inhibitory concentration for the maximum period of time is actually warranted. And in the patients which are concentration dependent, the trough levels are more important, peak levels are not important, they are more, trough levels are more important, such as aminoglycosides and vancomycin, where you should be their single 24th, that is OD doses, is better as compared to multiple doses in a day. So in so all these factors should be taken into account while selecting your antibiotics and the way you administer those antibiotics. So amongst the various choices which we have for MRSA, we usually use linezolid, teicoplanin, or vancomycin. There had been some literature of studying superiority of one over the other. But most of the studies, they found that actually the cure rates with both the antibiotics were equal, and number of adverse events were also not different amongst the groups. So there was no actual difference between linezolid and vancomycin. But in general, people are a bit hesitant to use vancomycin because of risk of nephrotoxicity. However, the same has not been demonstrated in clinical trials. There are newer alternatives for MRSA, which can be telavancin, tedizolid, or ceftaroline. All of them are in the various stages of recommendation. Few of them are FDA approved, but none of them have been proven to be superior to linezolid, vancomycin, or teicoplanin for lung infections. Important point to note is daptomycin. Daptomycin cannot be used to treat pneumonia because it is inactivated in the lung by surfactant. So daptomycin, contrary to the belief that it is a very good drug for MRSA, it should never be used in lung infections. A newer drug, ceftaroline, is a promising drug which has been FDA approved for patients with hospital-acquired pneumonia, but it has not been comparative studies with other previous predecessors is still lacking to prove its superiority over the previous ones. Others are ceftobiprole and tigecycline. They also have been approved by tigecycline have been approved by FDA for HAP, but not for VAP. But this new antibiotic ceftobiprole is yet to be studied in detail for use in CAP and VAP. For Pseudomonas, same thing. The antibiotics which we select should be taking in account the minimum inhibitory concentration in your antibiogram, and if the patient has got a dose which has got 95 to 99% suppression of the bacteria in the dose, is the minimum is the breakthrough point or the minimum inhibitory concentration at which the drug should be selected. And for more than 30% of the time, if the drug concentration remains above the MIC, the results are better as compared to when it is there for less than 30% of time. So prolonged infusions or of more than 3 hours or 6 hours have been recommended for patients who are in sepsis or septic shock with severe pneumonia. For Pseudomonas, in general, the recommendation is against a monotherapy with aminoglycosides. Dual therapy is recommended only in patients who have persistent septic shock or have a high risk of mortality. Otherwise, in mild to moderate pneumonias, single drug therapy with Pseudomonas can also be sufficient. Combination therapy for all other organisms such as Acinetobacter or carbapenem resistant organisms should be used with the help of the antibiotic susceptibility results. Ampicillin sulbactam or carbapenem is usually preferred. It could be combined with intravenous polymyxin. Intravenous polymyxin can be combined with inhaled colistin only when it is susceptible to polymyxins. Same is with carbapenem resistant organisms also. Some novel agents like ceftazidime avibactam, which has become nowadays is being used very commonly for hospital acquired pathogens. It's a newly used cephalosporin with beta lactamase inhibitors and has been approved for treatment for nosocomial pneumonia. And the clinical cure and the mortality rates were similar when comparing it with ceftazidime and 500 when comparing with meropenem. So the results were no different from the previous with meropenem. Other newer drugs like ceftolozane and tazobactam combinations, they have yet to be approved. Some other combinations of carbapenem with the beta lactamase inhibitors are also in progress. So for de-escalation of therapy, procalcitone is recommended in combination with the clinical criteria. and it has been found to be associated with significantly shorter duration of antibiotic therapy. However, there was no difference detected for duration of mechanical ventilation, ICU length of stay, clinical failure, or development of resistance. But it can be an important marker to de-escalate therapy along with clinical resolution of clinical signs and symptoms. For ventilator-associated pneumonia or hospital, 7-day course of antimicrobial is recommended by ATS IDSA guidelines. It's a strong recommendation. Longer durations are not recommended, and it is also, extrapolated to hospital-acquired pneumonia. But the data is extrapolated actually from the VAB data only. A meta-analysis recently done also showed that a 7 to 8 day course for ventilator-associated pneumonia or hospital pneumonia was as equal to the prolonged courses of more than 9 days with no difference in mortality, recurrence, treatment failure, duration of mechanical ventilation, and hospital length of stay. Some of the slides we can skip. The same has also been recommended for VAP with non-lactose fermenting gram-negative bacilli in studies as well as meta-analysis. Can we go shorter than 7 days? There is some data from a large study having more than 1,200 patients with suspected VAP. They have told that a patient who has received only 3 days of therapy compared with more than 3 days of therapy, the outcomes were equal. However, the studies it is too early to say that only 3 days of treatment for VAP is adequate. So for all practical purposes, the duration should be 7 days for most of the patient. 3 days may be sufficient for a small subset of patients, but same needs to be validated by larger studies. The duration should be guided by resolution of clinical signs and symptoms and clinical stability, and risk of mortality should be assessed before deciding for duration of therapy. Sometimes patients who have increased risk of mortality, a longer therapy may be given. So in this patient, the index case WBC slightly came down to 14.6. Ventilator requirements were also reduced. Procalcitonin was 4.2. Sputum culture from before starting antibiotics returned with this results. So what will we do next? We will discontinue all antibiotics and switch to a simple third generation cephalosporin and continue the treatment for desired duration, for the recommended duration. Thank you.